Good day, class. Today we're going to discuss about the classification and the laboratory assessment of anemias. So this will be my first time doing this one, so please bear with me if I have some mistake during the discussion. And also, if you have any question, please chat down it and I will answer it after the discussion or during our lesson proper. So yours truly, I will be going to discuss the the topic. I'm Reginald Ken Joseph F. Batistil RMT. Before doing the lesson, let's have the objectives. So what the objective will be as follows: causes of anemias. Define the term of anemia based on physiological description. Name the three causes of anemia and explain some of the factors contributing to anemia. Next will be the clinical signs and symptoms of anemia. State what causes the clinical signs and symptoms of anemia. Briefly describe the usual complaints of an anemic patient. The next will be the classification of anemias. Describe the organization of anemias according to erythrocyte size and explain the limitation of such a system. Then briefly explain the advantages of the categories of anemias using a pathophysiological basis. So now let's discuss about anemia. So this will be our first topic in Hema 2. So anemia. So anemia is from the Greek word anhaima, which meaning is without blood. As a definition, red blood cell anemia is a deficiency of red blood cell and or hemoglobin. So it should be both, not only in the RBC but also in the hemoglobin. So anemia is considered to be present if the hemoglobin concentration of the red blood cell or the packed red or the packed cell volume of RBC is below the lower limit of, take note, it is 95% reference interval for the individual, age, gender, and geographical location. The causes of anemia fall into three major pathophysiological categories. This will be the blood loss, impaired red cell production, and accelerated red cell destruction. This is due because of the hemolysis in excess of the ability of the marrow to replace these losses. So this is usually seen in chronic blood loss, wherein there is too much loss of blood and there is the replacement of the bone marrow is not that very good. Anemia may be a sign of underlying disorder. Dilution anemia with normal or increased total red cell mass may occur with pregnancy, macroglobulinemia, and splenomegaly. So it is in pregnancy we can experience anemia. So during pregnancy, women can experience anemia. Even though there is an increased red cell mass and increased plasma volume due to the hormonal changes, there is a relative increase in plasma volume more than the red cell mass. So there is a concentration is slightly less. Some anemias have more than one pathogenic mechanism and go through more than one morphological state, such as blood loss anemia. In the case of accelerated red cell destruction, hemolysis in excess of the ability of the marrow to replace these losses occurs. So what will be the clinical signs and symptoms of anemia? The clinical signs and symptoms of anemia can result from diminished delivery of oxygen to the tissue. Signs and symptoms of anemia are related to the lowered hemoglobin concentration. In addition, clinical signs reflects the rate of destruction of hemoglobin and blood volume. If anemia develops slowly in a patient who is not otherwise severely ill, hemoglobin concentration as low as 6 grams per dl may develop without producing any discomfort or physical signs if the patient is sedentary. The usual complaints of anemic patient are irritability, dyspnea on exertion. Other general manifestation this will be the vertigo, faintness, headache, and heart palpitation. The most common physical expression of anemia are pallor, low blood pressure, and slightly fever and some edema. In addition to these general signs and symptoms, particular clinical findings may be characteristically associated with a specific type of anemia. So what will be the most common so again, anemia is the most common sign will be the conjunctival pallor. The next other signs will be, at least take note, coilosyn coilosyn coilonsynchia, meaning spoon shape, spelling Koilonynchia. Koilonynchia. Atrophic glottitis. It is meaning ana is red large swollen tongue. Angular stomatitis or fissuring of at the corner of the mouth. High flow murmur because this is due to the compensatory mechanism of anemia, tachycardia, and dysphagia. Dysphagia means causes of pharyngeal web. How we're going to classify anemias? We need to classify anemias. There are so many different types of anemia exist, with many causes and manifestation. In attempt to organize anemia into understandable unit, several classification schemes have been proposed. This classification group anemias based on first electrocyte morphology, next is physiology, and the etiology. The method based on red cell morphology, which was originally proposed by Winthrop. So Winthrop proposed the red cell morphology categorized anemias by the size of erythrocyte. Anemias may be classified by red cell morphology as macrocytic, normocytic, and microcytic. So here is the diagram showing the picture of a microcytic cell, a normocytic cell, and a macrocytic cell. Take note, microcytic cell has an MCV or mean corpuscular volume of less than 80. Normocytic has a mean corpuscular volume of normocytic 80 to 100 femtoliter. While the macrocytic, the MCV is greater than 100. The major limitation of such classification is that it tells nothing about the etiology or the reason of the anemia. So here is the figure showing the how we're going to classify anemia basing on the RBC indices. The normocytic hypochromic, the normocytic and normochromic, and the macrocytic. So first will be the clinical signs and symptoms of anemia. It should be weaknesses, fatigue, and pallor, or the faintness of the skin can be categorized as anemic patient. So the doctor will perform or will requested complete blood count with differential, of course, RBC indices and morphology and reticulocyte count. What is the importance of reticulocyte count? This will signal if there is a anemia in the patient. If there is an increased reticulocyte count, this is due to the bleeding. While if there is no reticulocyte count or less than 1%, it can be either there is an impaired development of RBC. So one good example will be aplastic anemia. Next is hemoglobin decreases. So if the hemoglobin decreases in male, less than 13 grams per DL, and in female it is 12 grams per DL, uh, it is a good manifestation or a bad manifestation of anemia. So we have another parameters in order to identify if the patient is having anemia. First, if it is hemoglobin level of women is less than 12 and in men it is less than 13.5, while hematocrit in women it is less than 36 and in men it is less than 41. So let us classify it by RBC indices. If there is low MCV and low MCHC, it means it is microcytic hypochromic. It is due to the typical of maturation defects. So there is a maturation defects while the RBC is developing. This is due to iron deficiency anemia in some. Why in some? Because eh, iron deficiency anemia can be seen in normocytic and normochromic. Next will be thalassemia, and next will be sideroblastic anemia. Normal MCV and normal MCHC, or otherwise known as normocytic and normochromic blood picture, it is typical of hypoproliferation. It means hyperproliferation, decrease of proliferation of the bone, decreased proliferation of blood cells. So it can be either bone marrow disorder. For example of bone marrow disorder is aplastic anemia, Fanconi disorder. Next is iron deficiency anemia. However, iron deficiency anemia is normally seen in macrocytic and hypochromic, but some can be seen in normocytic and normochromic, especially in acute blood loss. Anemia of chronic disorder and autoimmune disease. Vitamin B12 deficiency, folate deficiency, and excessive alcohol ingestion, hypothyroidism, can be seen in high MCV, macrocytic, at same as low MCV and low MCHC. It's due to the typical of maturation defect. So recall, macrocytic, the MCV is less than 80. So it can be caused by the anemia belonging to this macrocytic is IDA, thalassemia, and sideroblastic anemia. Normocytic, the MCV is 80 to 100. The anemia is acute blood loss anemia, chronic disease, and leukoerythroblastic. The next will be macrocytic. The MCV is greater than 100. The anemia is vitamin B12 deficiency, folate deficiency, alcoholism, and hypothyroidism, including the liver disease. So there are several schemes have been proposed to categorize anemias based on etiology, but none of these classifications are entirely satisfactory because within each classification the various subdivisions are not completely inclusive. However, the physiological system has merit because it describes the the basic mechanism or probable mechanism responsible for the anemia. Although many classification schemes exist, a classification system that divides the major pathophysiological characteristic into three major categories is easier to understand the other system. So the three major categories is easier to understand. This will be accelerated erythrocyte destruction, blood loss, and impaired RBC production. So there is a modified organizational approach to this classification is used uh, and discuss the more frequent types of anemia. So later, in the next slide, you will see the categories of anemia based on blood loss, impaired production, hemolytic, and so on and so forth. Although the incidence of a certain anemia varies within different geographic areas of the world, among specific populations, some forms of anemias are generally more common than other. The most frequent forms of anemia result from either blood loss or IDA. Take note, IDA is the most common type of anemia. So here is the figure showing the categories of anemia basing of blood loss. Blood loss, either acute blood loss or chronic blood loss. Acute blood loss, it is a sudden loss of blood. And then acute chronic blood loss, it is a gradual loss of blood due to GI tract bleeding. The most crucial GI tract bleeding, it is upper GI tract. Impaired production, it is due to aplastic anemia, iron deficiency, sideroblastic anemia, anemia of chronic disease, and megaloblastic anemia. Next is hemolytic. It is inherited defects, acquired disorder, and last will be hemolytic hemoglobin disorder. So again, classification by pathophysiology, it can be either reduced production. So reduced production can be either insufficient and inefficient. Insufficient it means not enough co-elements produced in red blood cell. Again, insufficient production, this is due to not enough co-element to produce red cell. Example is your iron, vitamin B12, and folate. So this is a hematinic deficiency. So it is seen in iron deficiency. If you have lacking of iron, vitamin B12 deficiency, if you have megaloblastic anemia, and then so and so forth. Inefficient production, there's a problem in production of RBC. You can classify them into bone marrow infiltration or myelodysplasia. So what will be the laboratory assessment of anemia? The laboratory investigation of anemia involves the quantitative and semi-quantitative measurements of erythrocyte and supplementary testing of blood and body fluids. The result of this analysis provide the foundation for both the diagnosis and the treatment of anemia. Quantitative measurement of anemia. Anemia is a physiological defined as a condition in which the circulating blood lacks the ability to adequately oxygenate body tissue. So, anemia is like a dump truck wherein it loads oxygen in order to distribute each part of the body. For example, the dump truck is going to put the oxygen in the liver, next in the brain, and in the heart, and etc. etc. So there are three major laboratory manifestations of anemia. This will include the decreased hemoglobin concentration, the reduced packed cell volume or the microhematocrit level, and the decreased erythrocyte concentration. In addition to direct measurement of hemoglobin, packed cell volume, and erythrocyte count, a variety of other measurement or calculation can yield additional information. This assessment include the RBC indices, the red cell histogram, and the red cell distribution with RDW or red cell morphology index or RCMI. So what is RBC indices? RBC indices calculated parameters that are part of an automated blood count report. RBC indices have two primary uses: assist with the differentiation of anemias, serve as a quality control checks. So here is the definition, unit, and the formula in each of the parameters in the RBC indices. These are the common parameters. We have so many parameters in RBC indices. There are so many indices. The RBC indices, WBC indices, and the platelet indices. But the most common indices will be the RBC indices to classify what type of anemia is that. So first parameter is mean cell volume or the mean corpuscular volume or MCV. Definition is it is the average volume of an red blood cell or RBC. Unit will be femtoliter, FL, or 10 to the negative 15 per liter. So recall, what is the unit used in MCV? A femtoliter, B picogram, C grams per deciliter, D percentage. So the answer is femtoliter. Formula is MCV is equals to hematocrit percentage times 10 over RBC times 10 to the 12 power per liter. Mean cell hemoglobin or MCH, or it is also called as mean corpuscular hemoglobin, it is an average weight of hemoglobin in the RBC. Again, average weight of hemoglobin in the RBC. The unit is picogram, or it is 10 to the 12 to the negative 12 grams. MCH is equals to hemoglobin grams per DL times 10 over RBC times 10 to the 12 power per liter. Then lastly will be mean cell hemoglobin concentration or MCHC, or the mean corpuscular hemoglobin concentration. It is the average concentration of hemoglobin in the RBC. So the unit will be grams per deciliter or grams per DL. MCH C is equals to hemoglobin grams per DL times 100 over hematocrit or it is in the percentage. Next is RBC cell histogram. These are geographical representation of numerical data of different cell population on cell counter. This is well discussed during your automated in hematology. And lastly will be red cell distribution width or RDW, or red cell morphology index or RCMI. It is a parameters that measures variation in red cell size and red cell volume. Is elevated in accordance with variation in red cell size, or it is so-called anisocytosis. Variation in red cell size, meaning of that it is anisocytosis. So the reference range of RDW is as follows. RDW SD or RDW standard deviation is 39 to 46 femtoliter, while RDW CV or RDW coefficient of variation, it is 11.6 to 14.6% in adult. The next, so here is the diagram showing the relation between the MCV and RDW in assessing anemia. First is high MCV and high RDW. It is classified as megaloblastic anemia, while normal MCV and RDW is high. It is seen in normocytic anemia, while it is in low MCV and high RDW, it is seen in iron deficiency anemia. High MCV normal RDW is seen in aplastic anemia in adults. Normal MCV and high RDW normal RDW is seen in reticulocytosis, while low MCV and normal RDW is seen in heterozygous thalassemia, anemias of chronic inflammation or disorder. In some references, there are some types of thalassemia wherein there is an high RDW and low MCV. Semi-quantitative grading of erythrocyte morphology. Direct observation of the peripheral blood smear for abnormalities in erythrocytic morphology or immature erythrocyte can yield additional information. In addition to the identification of erythrocyte abnormalities, erythrocyte morphology may be determined semi-quantitatively to reflect the severity of the abnormalities The best area on the blood smear for the examination of red cell morphology is where the red cells are barely touching to each other but not overlapping. Additionally, under 10 power, it is possible to evaluate relative number of white blood cells. Take note, the best area on blood smear for the examination of red cell morphology is where the red cells are barely touching each other but not overlapping. So it is part on the feathery edge, but not totally on the feathery edge. So take note, there is one WBC for every 500 to 1000 RBC. If there is more than one WBC, it can be either the patient is having leukemia. While if there is one platelet for every 5 to 10 red blood cell, uh, it is a good manifestation that it is a normal condition. So please take note, this figure showing a normal peripheral blood smear. The mature erythrocytes are of normal size, showing central pallor, and there is a neutrophilia and a monocyte. So there is a what is this? This is a monocyte. Sorry, this is my first time doing this one. So again, so we have monocyte. The next picture, it is peripheral blood smear showing morphologically normal RBC, platelet, and a small lymphocyte. So this is a platelet, platelet, platelet. What else? So this is a small lymphocyte. Next, it is a nutritional anemia seen in IDA. IDA, where is that? IDA. So, there is a microcytic and hypochromic. The next will be a macrocytic. It is a peripheral blood smear from a newborn. So what you expect if it is newborn, there is some cells are not yet developed, not well developed. So in grading the erythrocyte morphology, it is in semi-quantitative grading. We are still in the semi-quantitative grading of erythrocyte. Erythrocyte changes are commonly reported using either descriptive term such as moderate or marked, or grades or numerical scales such as 1 plus, 2 plus, 3 plus, or 4 plus. The characteristic of such grading may vary from one laboratory to another, but will generally conform to the scale as presented. So this will be the grading. So 0, the description of that one will be a normal appearance or slightly variation of erythrocyte, especially if they're in the feathery edge, you can see the anisocytosis, but it is just a normal because when you have a force, the cell will be distorted. 1 plus, a numerical scale of 1 plus, only a small population of erythrocytes display a particular abnormality. The terms slightly increased or few will be comparable. 2 plus, more than occasional numbers of abnormal erythrocyte can be seen in a microscopic field. An equivalent descriptive term is moderately increased. 3 plus, severe increase in abnormal erythrocyte in each microscopic field. An equivalent descriptive term is many. And 4 plus, the most severe state of erythrocytic abnormality, with abnormality prevalent throughout each microscopic field. The comparable term are marked or marked increase. So there are supplementary assessment of anemias, other procedures that support the diagnostic process of identifying an anemia may be needed. Some of these assays are performed in the hematology laboratory and other may be performed in other sections in the laboratory. The bone marrow examination may be performed may reveal an abnormal ratio of leukocyte to erythrocyte, the myeloid erythroid ratio. So let us recall in our next lesson what will be the normal myeloid erythroid ratio. Myeloid is for WBC and erythroid is for the RBC. Other maturational irregularities or unusual cellular elements may be observed. The following procedures may be provide the information. This will be the fetal hemoglobin concentration or the hemoglobin F. Next is malarial smear. You need to identify what type of malaria is invading the patient. It because even though you had identified it the patient is having malaria, but you need to speciate it whether it is a Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. But also there is Plasmodium knowlesi found in Palawan, but it is not that significant. Platelet count, it is important to assess, especially in a plastic anemia, because plastic anemia is not solely in RBC but also in all other blood cells, including the platelet and the RBC. In platelet and WBC. Reticulocyte count, it is important to assess if there is a good production of bone marrow in replacement of the blood loss. If there is an increased reticulocyte count of 3%, it means there is an excessive bleeding and the bone marrow is normally functioning so that to compensate the loss of blood. Sickle cell testing is to test if the patient is having a sickle cell anemia. Glucose 6-phosphate dehydrogenase or G6PD assay is a common in the Philippines. Why? Because mostly babies having this disorder is not will not survive very long. That is why we need to understand we need to have a newborn screening for this one. Uh, the blood picture of the patient having G6PD will be discussed in the discussion next time. And the hemoglobin electrophoresis. Hemoglobin electrophoresis is good to identify thalassemia and other hemoglobinopathies. The next is additional procedures may be assistance in identifying specific type of anemia but are usually performed in other section in the laboratory. This will be the antibody screening and the identification test and direct antiglobulin test. This test is used to identify whether the the RBC is coated with IgG or warm reacting antibodies. So if there is a warm reacting antibodies, there might be a phagocytosis will happen. The macrophages will identify it as a foreign. So the macrophages, especially in the spleen, will going to phagocytize it, and eventually there is a hemolysis. Then next is the measurement of bilirubin level. Bilirubin, if there is an increased bilirubin, it means there is an excessive hemolysis. Next is folic acid. If there is a deficient of folic acid, it means there is a folic acid deficiency. Measurement of haptoglobin level, lactic dehydrogenase determination LDH. So later you will know what is the importance of this haptoglobin, the LDH determination, serum iron, and total iron binding capacity, and vitamin B12 assay. Occult blood testing is important to test if the GI tract is that there is bleeding in the GI tract, especially in upper GI tract. Occult blood means hidden blood. Urobilinogen screening is used in accordance to your bilirubin level. So if there is an increased bilirubin, so expectedly there is an increased urobilin. So thank you for listening my report. But first, I will going to give the conclusion in the discussion. Anemia is considered to be present if the hemoglobin concentration of the RBC or the packed cell volume of RBC, it is termed as hematocrit, is below the lower limit of 95% reference interval for the individual's age, gender, and geographical location. The causes of anemia fall into three major pathophysiological categories: the blood loss, impaired red cell production, and the accelerated red cell destruction. Anemia may be a sign of underlying disorder. The clinical signs and symptoms of anemia can result from diminished delivery of oxygen to the tissue. Signs and symptoms of anemia are related to the lower hemoglobin concentration. The usual complaints of anemic patient are easy fatigability, dyspnea on exertion. Many different types of anemia exist with many causes and manifestation. Classification group of anemia is based on erythrocyte morphology, physiology, and probable etiology. The method based on red cell morphology categorizes anemias by the size of the erythrocyte. Anemia also may be classified by the red cell morphology as macrocytic, normocytic, and microcytic. The laboratory investigation of anemias involves the quantitative and semi-quantitative measurement of erythrocyte and supplementary testing of blood and body fluids. The result of this analysis provide the foundation for both the diagnosis and the treatment of anemia. So, class, thank you for listening and God bless. After the discussion, please repeat the video for the familiarization because we will have a quiz in our lesson proper. So, God bless.